this was a hard topic because it's like, let's talk about all of neuroradiology plus ultrasound of said abnormalities. So I kind of tried to focus on things that we have had issues with, or maybe just me. And I'd love your thoughts on several of these topics, especially you guys in the chat. So I thought we could start with what we do at our institution as far as protocol, with some imaging examples of that, and then talk about topics with case faces. You guys all know this as pediatric radiologists, but the whole reason we were able to do this is because we have these beautiful open windows in the skull to be able to put our transducer and see. And so all of these marked arrows are places that we can use as windows. This kid did have a palpable abnormality. That's why there's a BB here. But our primary workhorse is the anterior fontanelle. And then we use a lot of the mastoid fontanelle also. The posterior fontanelle and foramen magnum we really only use for problem solving. It's not part of our protocol. Okay, we still have, at our institution, we are a large, quaternary referral center, but we still read for lots of other sites. And so one of our sites still has a sector transducer. So at that institution, this is what we get, and the detail is not as great. At all of our other sites, we have a nice little baby head probe, which fits over the anterior fontanelle nicely. So as part of our protocol, we always image through the anterior fontanelle with 2 transducers. If we're at one of the sites with the baby head probe, we'll use that. And then we'll follow that up with a linear high frequency transducer. So you still get that depth through the entirety of the brain, but you do lose a little bit of the peripheral aspect of the brain. And that's why I still like to have both of the transducers when we do our imaging. We do cine clips anterior to posterior in the coronal plane. We also do sagittal cine clips with both transducers, right to left, left to right. At some sites, they sort of stop midline, which is okay with me. Whatever they want to do, as long as the side they're looking at is labeled. Then we get these coronal off-axis images looking for any abnormalities along the peripheral aspect of the brain, or any kind of extraaxial collections off laterally, trying to window especially kids on ECMO. We do, for every head ultrasound, we have started to do a spectral tracing of the anterior cerebral artery. And that's mostly because our sonographers kept forgetting to get it when the indication was hypoxic ischemic injury, or the clinicians would put something that the text didn't recognize as being the concern is actually hypoxic ischemic injury. So we've updated our protocols so that every first head ultrasound we get at this institution will include a spectral tracing of the anterior cerebral artery. The other thing we do is we look at the extraaxial spaces closely. So we get a magnified image with and without color of the subdural spaces at the vertex, looking for structures coursing through that. Plus we look at all of the dural venous sinuses that we can. So the superior sagittal sinus at the vertex, and then depending what level we're at on our mastoid view, we'll get color images of the either sigmoid or transverse sinus, depending where the tech is. I like for them to label what side it is, even though through the anterior fontanelle, you can typically guess what side the abnormality or normal patent sinus is. We will use either color Doppler, most commonly power Doppler if we need to. And at our institution, we don't have that orange color for power Doppler. It's blue and red. And then we'll also use microvascular imaging if they're having a hard time getting flow in that dural venous sinus or some of the tiny little cortical veins. I found microvascular imaging to be super helpful for proving that there's flow in a structure. Just a quick reminder, this is what I find this view is the view most people are confused by. It's maybe newer for some people reading head ultrasounds, but you can see all of the posterior fossa and deep anatomy beautifully. I love cines also because it's a good time to look along the tentorium, along the hemispheres of the temporal lobes. And then you can also even see like brainstem structures. And if there's a question for like posterior fossa cystic spaces, I find this view super helpful, especially on if they give me cines. Yeah, we've picked up lots of subdural hemorrhage on cines of this mastoid view. You know, are they significant or not? You can get birth-related subdural hemorrhages, but it's still nice to be able to point those out, I feel like. We rarely get images through the posterior fontanelle because the images, quite frankly, aren't as pretty as some of our other views, but I think it's good if you're questioning some sort of hyperechogenicity in the posterior periventricular white matter. I don't know if you guys have found it to be more helpful, or do you have that routinely in your protocol, this view?
We do not. It's pretty rare that we get these images. It's like you said, it's mostly for problem solving, and it's pretty much at the discretion of the tech whether they decide to get this or not, but it's pretty rare that I see it.
Yeah, agreed. Okay, so that's what we do for most of our protocol, and, you know, additional images. I thought we could jump into some cases now for discussion. So the first case is a term infant who had a home delivery with the midwife and who had a poor transition. And this case I'm showing because I opened the study and I was like, holy hats, I don't know, bad abnormalities everywhere. We have funny looking ventricles with these weirdo like superior extensions, and then everything is just a little bit too bright. And here it is in the sagittal plane. And when I was reading this case, I of course ran to one of my neuroradiology colleagues, and he reminded me of this. This is like one of, I love Monica Appleman. I feel like almost everything I've learned in ultrasound and head ultrasound is from something that Monica has written. But I think this is helpful for, just because it's a, you know, an anechoic structure doesn't mean that this article is not relevant. So of course I learned about conodal cysts from this article, but the location of the cystic abnormality, based on the location, you can know like what it is. And so in this case, we have these abnormal cystic changes that are superior to the apex of the frontal and lateral ventricle, like the teardrop. And so this, oh yeah, here's the MRI on this patient. And so this was in utero, grade 4 germinal matrix hemorrhages, or periventricular hemorrhagic venous infarction is the new term. Plus, all of the brain was abnormal. So the choroid plexus is your internal control. And if you compare the white matter of the echogenicity of the white matter surrounding, everything was as bright or a little bit brighter than the choroid plexus. So one of my attendings when I was a trainee told me that rule number 1 on any whole ultrasound is that the choroid plexus should be the brightest structure in the brain. And I still, every head ultrasound, I still find myself saying that. Thank you, Dr. Brody. This also leads me to, oh, that'll be a next case. Any comments about this from any of my fantastic co-moderators?
Judy, I want to say I think it's really great that you brought up the choroid plexus as the internal control, because in ultrasound, hypoechoic, hyperechoic is always relevant to something. And especially my trainees and my fellows particularly freak out about hypoxic ischemic injury and white matter changes, because they're like, how bright is too bright? And it's nice to have that internal control to compare to. And so I think that's a really important point.
Yeah, I totally agree. And I, you know, in a case like this, especially where it's kind of a diffuse symmetric abnormality, I think it's, you know, the ventricles are clearly abnormal, but the brain parenchyma I find can be very hard when it's a diffuse process. So having something that you have as an internal control like that is definitely a good point. That can be very valuable to have something to compare to.
Yeah. Okay, let's go to the next case. So this was a 2-month-old former extremely premature twin infant who was actually transferred to us from an outside hospital. And during our morning NICU rounds, apparently the read at the outside hospital was follow up the grade 4 germinal matrix hemorrhages that were diagnosed at the outside hospital. And we freaked out because we thought we had scanned the wrong patient. Honestly, we thought there was a patient identifier mismatch, because this is not a normal head ultrasound. The ventricles are a little bit dilated, the lateral ventricles, and the extraaxial spaces are also big, but the white matter looked really pretty normal otherwise. And so going back, of course, the next day, not the day that we read this head ultrasound, they uploaded the outside institution images. And so at the outside institution, this was what this patient looks like on day of life 1. So several studies prior. And you can see what they were calling a grade 4 germinal matrix hemorrhage. So there's this abnormal echogenic material kind of underneath the lateral ventricles, and it's sort of extending along the inferior margin of the lateral ventricle. It's not really within the ventricle itself, and it's not actually in the periventricular white matter either. I'll show you what it looks like on the sagittal plane. So you can see it's just kind of like parallel to the posterior aspect or maybe midpoint of the lateral ventricle. I'm not sure which side this is, but both sides look pretty similar. And Dr. Lizzie Snyder has taught me several things in life, and this is one of the more recent. So she was the first one, to my knowledge, who described this germinal matrix hemorrhage of the posterior germinal matrix. And this is something that eventually we need to get together with our neonatology colleagues and update this grading system. So you guys know it's based on the 1978 Papil classification, which was based on CT, and we didn't have 22-week infants surviving. So you'll also know this if you read fetal MRI. The germinal matrix is an, oh my God, vascular structure. It's a transient zone of neuron and glial proliferation and migration, and we can actually see it at head ultrasound without hemorrhage. So at fetal MRI, it's this dark structure that is kind of parallel to the undersurface. It parallels the caudate underneath the lateral ventricles. And on head ultrasounds without superimposed hemorrhage, you can see it as this hypoechoic structure, like kind of underneath the ependymal lining of the lateral ventricles. And next we'll see a cine of that. It's just this hypoechoic stuff. I've seen it with a little bit of kind of hyperechoic look to it, but no mass effect on the like above lateral ventricle. And so when you have hemorrhage of this normal structure, it's kind of hard to classify. Like it's not actually in the ventricle and it's not actually in the adjacent white matter. It's just subependymal, kind of parallel to that lateral ventricle. So this is another case of a germinal matrix hemorrhage of the posterior aspect of the germinal matrix. I think I have a cine of this case too. I am descriptive. I would love to know how you guys report these. I just sort of describe it as, you know, hemorrhage of the posterior aspect of the germinal matrix and, you know, any associated abnormalities. But some people will say, oh, I'll call this a grade 3. But to me, it's not in the ventricle, right? So it doesn't really fit with grade 3. How do you guys grade this one?
Yeah, no, I think this is definitely a challenge. And, you know, like you said, I don't think that we have accurate, you know, literature and grading scheme to really capture this. You know, that we had this particular article was discussed at one of our departmental journal clubs within the last year or so, shortly after the article came out. And that was one of the conversations that came out of this. You know, technically this is a grade 1, but, you know, just looking at the volume of blood in there, it doesn't really, it kind of feels weird to call it a grade 1. So I don't have a great answer to your question. I think being descriptive at this point in time, you know, as far as I know, I don't think that we have great data on, you know, what the outcome of these patients and kind of the counseling and prognosis for these patients, which I know that, you know, our NICU likes to have grade just because they use that to talk to families. But, you know, I think this is one where there's a real kind of gap in our knowledge as far as what we know about the long-term outcome of these, as far as I know.
Yeah, I agree. I think these cases are always challenging for us in radiology because we often argue a little bit about how we should grade this. Our NICU similarly really wants a grade because it also helps them to counsel families and to plan follow-up. I tend to be descriptive. I also tend to lean really heavily on the follow-up imaging. And we'll comment retrospectively if the follow-ups, like in this case, have changed really significantly. But I agree. I think we're just starting to see babies of this gestational age hitting our NICUs, and this is something that we need to be following as radiologists to see what the outcomes actually are.
We've had several 22-weekers. It's like crazy.
Yep.
Mm-hmm.
Go ahead, Hypoxic, sorry.
No worries. No, I completely agree. Like, I feel like our, like the babies that are delivering and surviving are getting later and later. So we're probably in uncharted territories here. But I do have a kind of like a piggyback question is that, the NICU will always push us to give like obviously a grade, and I try to, but on follow-up, I find like that's kind of difficult for me too, because, you know, is the grading based off of just the initial, or is it, you know, a continual evolution? I don't know if that's ever been established. Like, can we regrade or, you know, change it, upgrade, you know, like what is all that? Like, what do you guys feel about that?
Yeah, I think that's a really good point, because it can be really challenging. And our practice has been to provide the grade that we see on the study that we're seeing it. So the grades do change sometimes, right? And often my report will say initial grade 1, now grade 2, initial grade 3, now grade 3 resolving, types of things. But it's the other big challenge with having this very outdated grading schema. And the grading schema and the language is so challenging to know exactly what to say and how to say it exactly correctly. That I think we're all still just trying to figure it out. I'd love to hear, Jeff or Judy, how you guys do it.
I was always taught that germinal matrix hemorrhage is like hips. You grade it on the first one and then you describe what happens on follow-up. So I would actually love the ability to, oh, just kidding, now it's a grade, you know, whatever, however it's changed. One of the things I always say is be descriptive. So I just kind of describe what I see as best I can and how it's changed. I don't have a good answer though.
The particular area I've struggled with is with grade 3s, because some of the conversations I've had with our NICU is that, you know, my understanding of the grading scheme is that, you know, if you have a bleed and then if you develop a post-hemorrhagic hydrocephalus, does that really count as a grade 3? I don't think so. So, you know, we have the initial one where they have maybe a grade 2 and then they develop some degree of obstruction from the blood and they get some ventricular dilation on follow-up. It doesn't feel quite right to call that a grade 3. So I think that's where, at least I personally, I think I probably tend to grade it on the initial ones and then be more descriptive on the follow-up, because I think some of the, you know, some of the nuance is lost with those follow-ups and kind of as things evolve with the hydrocephalus.
Yeah, I take a similar stance as you, especially with like if the patient presents and they have intraventricular hemorrhage and they're dilated at the time of initial, you know, bleed identification, then it's a grade 3. But then I say, you know, evolving intraventricular hemorrhage and then describe how the hydrocephalus has changed.
But you're right, Judy. This is where it would be so great to sit down in a room with a bunch of people and say, how do we really want to do this better?
Yeah. Yeah. And somebody should really correlate with neurodevelopmental outcomes and how these kids act. Yeah. Somebody with more time. Eric, I nominate you. Okay. Oh, yeah. So a reminder, so to compare with, it's not actually grade 4 germinal matrix hemorrhage. Our neonatologists sometimes still want us to say that, again, just so it fits in their algorithm of how they care for and treat these patients, but it's really a periventricular hemorrhagic venous infarction. I mean, if you think back to that, that pathologic specimen with these teeny tiny little thread-like vessels, you know, you get a clump of 2 red blood cells and that vessel is clotted off. So anyway, the other thing is I wanted to show this and how PHVI evolves over time. So how do we know without having the comparison images of that first example case that it wasn't grade 4? And that's because the periventricular hemorrhagic venous infarction typically has cystic evolution over time and becomes a porencephalic cyst. And that kid had pretty near normal white matter. Our case of posterior germinal matrix hemorrhage. Anyway, the other thing, just to kind of distinguish between is white matter injury of prematurity or encephalopathy of prematurity or PBL, or however you wanted to say the same pathology but different terminology, is how I have a hard time with periventricular hyperechogenicity. And this is one where the follow-up over time I find is incredibly helpful, because the cysts are like, oh yeah, clearly those are cysts that are forming over time and they're in the classic location, like anterior to the frontal horn, lateral ventricle, and kind of in the posterior parieto-occipital regions. This is that patient's MRI. And I'm curious about your guys' thoughts. and how you deal with what I've been told is called flaring. So, we wait until 1 week of life to do the screening head ultrasound to catch as much of the, for premature kids, to catch all of the germinal matrix hemorrhage that's probably going to form. But I find the white matter to be as echoic as the choroid plexus almost all the time in these patients, particularly posteriorly. So do you guys just say probably normal for age and follow up at, after 1 week of life? It's not a big deal for me when the kid's older than 7 days, because supposedly flaring doesn't happen after that point. But when you get these abnormal head movements, concern for seizure, drop in H&H, and you find them, you're doing a head ultrasound before 1 week of life, what do you do?
I do exactly what you just said. I describe it. I always describe it. I comment on whether it's symmetric or asymmetric, because sometimes that's helpful. And then strongly encourage a follow-up. And if it goes away, assume that it's flare. And if it doesn't, then continue to follow it.
Yeah, I agree with all that.
Good. Mostly I'm like, am I doing this right? So thank you guys. Oh, I feel like you have to go through the other germinal matrix hemorrhage grading. So grade 1, it's the traditional anterior germinal matrix where you get blood. And I like to show normal comparisons for my trainees. So if you, on the sagittal view, the caudate is that white asterisk, the thalamus is the purple asterisk. And so if you have anything sitting on top of or anterior to the choroid plexus, right in that little groove, that's the grade 1 we're talking about. I find grade 2 hemorrhage incredibly challenging because it can be hard to distinguish the choroid plexus from blood. When it extends anteriorly, obviously we can see that, but when it's kind of just chilling on top of the occipital horn choroid plexus, I find it more challenging. And then 3, I feel like is the easiest, because it's like, oh, well, there's blood and the ventricles are big. And the ventricles are big, so you can actually see the blood. Yeah, this was just this child's follow-up. Okay, this is the last of this topic, although I'm sure we'll touch on this for other cases. So this was a patient who had a drop in H&H, and so we got a screening head ultrasound prior to 1 week of life, and you can see this right periventricular hemorrhagic venous infarction. And then we got a follow-up 1 day later. You can see maybe there's a little bit of evolution, but there was another finding, and it's maybe more important than the right former grade 4 germinal matrix hemorrhage, and it's this posterior fossa. So this is where I scrutinize my transmastoid view to try to say, okay, is this within the cerebellum itself? Is this extraaxial pushing on the cerebellar hemisphere? And sometimes that can be challenging. I find this one was clearly within the cerebellar hemisphere. And supposedly posterior fossa hemorrhages are more potentially clinically significant, like with increased risks of morbidity and mortality, but also the space is smaller. So smaller amounts of blood can cause compression of very important structures. I love that mastoid view. I love Sene's of the mastoid view. So, okay, let's move on to the next topic. So this was a term infant who had a prolonged, difficult delivery and who presented with seizures. And so I find these to be probably the most challenging, where everything is just a little bit off. So we do have a little bit of slit-like lateral ventricles, which can be normal, but the deep green nuclei are just a little bit too bright. I'll let this play through one more time. Compare basically all of our white matter and gray matter to the choroid plexus once we get to the posterior aspect here. And everything is just about as bright as the choroid plexus, almost. So this is, and a normal for comparison. And this was the anterior cerebral artery resistive index, and this was low. Okay, so let's talk about RIs. So a reminder of the formula of resistive index. So peak systolic velocity minus end diastole divided by peak systole. And I think that RIs are very challenging because a lot of things can impact the RI, including age and the day of life that you sample and some of the therapies that they're doing. So in the literature, depending what you look at, the depending which article you reviewed, the normal values will vary from premature through term infants, and by a percentage. I'm like, I hate numbers and I always have to look up numbers. And so I kind of just in my mind think 0.65 to 0.75 is normal, and anything too high or too low is not normal. The thought with hypoxic ischemic injury is that you have disrupted cerebral autoregulation with supposedly increased diastolic flow, leading to a decreased resistive index, right? So you're dividing by a bigger number. And according to some very old literature, if you have a resistive index lower than 0.6 in the first 48 hours of life, that is associated with poor neurologic outcomes. So, oh, and just a point of clarification, when we say a resistive index of the ACA, it's really the pericallosal branch, like kind of where it swings around after some of the branches have come off. But not all of the articles specify that, but when you look at the images, it's always the callosal branch. So just one point of clarification. So in this patient, we had diffusely abnormal gray and white matter and a low RI, much lower than 0.6. And this was this patient's follow-up brain MRI following cooling. So this was one of the cases where, we actually our techs did remember to get the ACA Doppler tracing on the first head ultrasound. It's hard to get in there before they start cooling though, and that will have an impact on the resistive index. And this was the MRI that was about 3 weeks later, just extensive, oh my gosh, badness. But this patient actually is a couple of years old now and is still surviving because there was some sparing of deep structures. A companion case, again, we have a pericallosal ACA Doppler tracing with OMG, low resistive index, but this was this patient's abdominal radiograph. And this was the best case of pneumatosis intestinalis, where nobody wants to hedge on this. This is legit pneumatosis. So a lot of things can impact the resistive index. And I say everything, I'm kind of being a little bit snarky because I got to be myself, but just their cooling with suspected hypoxic ischemic injury will alter the anterocerebral, the waveforms. It'll alter the waveforms. PDA will give you like diastolic reversal. So supposedly with hypoxic ischemic injury, if you have reversal of diastolic flow, that's like impending brain death. But you can have that also with the patent ductus arteriosus, which we don't always have that history available at the time of imaging. Similarly, pulmonary hypertension can impact the ACA-RI. So I would love your thoughts about how you guys handle these cases. Do you routinely get ACA tracings just for specific indications?
I have one kind of quick protocol question before we dive into that. Do you do a Doppler charge on these? That's one thing we've kind of run into this particular issue. We've been told that, even like for, soft tissue vascular anomaly or something like that, you can do color on it without having to do an additional charge. But once you do a spectral waveform, it adds that Doppler charge. Do you change anything as far as your billing or coding with doing ACA Doppler?
We don't bill for it.
Okay.
You're exactly right. If it's color or power Doppler or microvascular imaging, there's no charge. But if you throw a spectral on there, theoretically you could charge. We don't do that.
Okay. Good to know.
Are we missing out on revenue, or is that, what do you think?
Yeah, I mean, I've been told by our billing department that we have to accurately code and bill either way. Like we can't do more than we charge for, and we can't do less than we charge for. So they've been kind of picky with us about this type of thing, as far as doing things that we could bill for and not billing for it. So at least, and where I did fellowship, we just kind of added it on like you did, and there's no issues with it. But at least at where I am now in Colorado, they're more picky about, being precise with charging for the images we do. But
and is that like a separate code, or is it mainly just within your technique, saying like, using grayscale, color, and then spectral analysis?
So for us, we have the coders kind of look at our technique to see if everything matches. So like for an MRI, for example, if it's ordered as a with and without contrast, our technique and our report has to match that. We have to say with and without contrast. So for ultrasound, it's similar. We the coding and the billing has to match what we describe in the technique of our report. So if we do Doppler, we have to say we did Doppler, and it has to be as part of the order, that the Doppler order has to be a part of that.
Okay, so you would have to create like a brain ultrasound with Doppler then.
Correct. Yeah, like for pelvis, we have pelvis with Doppler and pelvis without Doppler. So if we do spectral waveforms, we have to use that with Doppler.
That's a great point. And I think I feel lucky that I'm with Judy in the camp that I can add it on to every single one of my head ultrasounds without having to do that. So we've just built it into our protocol. And for us at CHOA, especially because we have our NICU in our own freestanding children's hospital, ×2, but we also cover NICUs at multiple adult mother-baby hospitals, and we're the ones who are reading the majority of their head ultrasounds. And so it's been very important for us to have a very standardized protocol so that we can have all of our techs, no matter where they are in the city of Atlanta, giving us the same information for every single baby. And it's just easier to get them to do it every single time. I think it's also good for our technologists, our RADs, and our trainees to remember to look at that RI every single time. One of the best ways to know what normal is to see it over and over and over and over and over again. So we do get an RI on every baby. We will report them. We actually put the numbers in our standard template report. So they are there for any of the referring clinicians who might want them. We will call if we have findings of white matter injury and we have a very low RI. And we will also call if we have high RIs or reversal of flow, just because we consider those to be important data points to be sharing with our NICUs. Sometimes they don't know that the PDA has become hemodynamic. They know there's a PDA present, but they don't know that they're now getting reversal of flow in their brain. And that's important because that's the PDA you want to clip. The other times that we see in our practice that the RI is really helpful is in patients who have hydrocephalus. And they're trying to determine when does the intracranial pressure get high enough that that baby needs a ventricular shunt. And they'll be looking for RIs of 0.9 or even 1, and that will kind of tip them over the edge. Maybe the child hasn't yet had clinical signs or symptoms of increasing intracranial hemorrhage, but the resistive indices are showing all of the findings that tell them our ventricles are getting too big. We now need to start shunting the patient.
Do you do the compression? I know in some studies it's like, oh, you compress if it's less responsive or less RI change.
So I trained in Boston, and which means I trained with George Taylor. So I am a true drinker of the compression RI Kool-Aid, because he is also a firm and true believer. I did that at my initial practice at the University of Wisconsin, and it's very helpful. It's actually our neurosurgeons there became true believers as well. So the idea behind the compression is that you, with your transducer on the anterior fontanelle, while you're doing your ACA Doppler, you do gentle downward compression on the anterior fontanelle. And then you always do it in real time, and you will watch the resistive index change in relationship to the pressure that you're putting on the anterior fontanelle and the minute changes of internal intracranial pressure. And you'll actually watch the vaso kind of reactivity, and you'll watch it come back to a normal Doppler, a normal RI. Or you'll see that there is no response to normal, and that's a child who is on the cusp of increased intracranial pressure, such that any additional pressure means that they're just going to have reversal of flow. So I think it's useful in very specific populations. We don't do it here because our neurosurgeons aren't as big a believer. And so we haven't had the clinical kind of need for it. They look at just the single RI and they make their decisions off of that.
Yeah, I know there's also, I think, some work being done at CHOP using microvascular imaging to look at brain perfusion to see if that could be a kind of a marker of who's going to respond to shunting. So I think that's going to be really interesting to see that gets fleshed out. You know, I think it's a similar concept to using those ACA compression images, but, you know, maybe, you know, a little bit more consistent, but, you know, I think it'll be interesting for sure to see what comes out of that.
Agree. I think there's a lot there. And then exactly.
I was gonna ask you, actually, I thought I had a slide about, so do you provide measurements for your ventricle sizes for your neurosurgeons as well, or no?
So we do have measurements that we give. We do our measurements on the coronal plane, and we do a anterior, like transfrontal, transoccipital, compare it to transcalvarial measurements. You can actually do ratios.
Yeah.
I don't have it offhand, but there's a publication out there that shows that those measurements are the most consistent with MRI measurements.
Yeah,
So,
there was RUPA, the Indiana group. Yeah.
Yep, exactly. So we do give those as well in those hydrocephalus patients. And then we are now, our adult neurosurgical team and neurovascular team has us do Lindegard ratios for all of our pediatric patients with subarachnoid hemorrhage. So we are doing those as well. At CHOA, it's been a really interesting process though, because we're one of the biggest sickle cell centers in the country. It's Atlanta. We do more sickle cell TCDs than probably anybody else in the country. We're doing upwards of 20 of them a day, most days. But we have the old school Doppler for that. So we don't get
imaging.
Yes, we do not do visual TCDs. We just get the waveforms. So the very first
and you guys report, do you report that, or does the hematology group report this?
We do it.
Oh, all right. I'm gonna stop complaining about my job.
Yeah, no, it's been fast as a true like vascular geek. It's been really fun to learn. But the very first time they asked us for a Lindegard ratio, somebody actually trundled our big old non-visual TCD machine up to the PICU to do it. So now we actually do our Lindegards. We do them visually. We have a GE machine that allows us to do visual TCDs and do them beautifully. If you are going to be starting to do Lindegard ratios in your practice, you probably want to touch base with one of your neurosurgeons though, because that Lindegard ratio is very important and you have to be reporting the right numbers. And the number that you report is different than the number you report for your sickle cell TMAX.
Yeah. We also had a learning curve with vasospasm protocol.
Mm-hmm.
Yeah. Okay. I do have hydrocephalus measurements, but clearly not this slide. Maybe next. Okay. Next topic. This was a 7-month-old former late preterm infant with an enlarging head circumference. And so you can see there are big extraaxial spaces at the vertex. The ventricles, I think, are a little bit on the mildly dilated side with kind of rounded frontal horn lateral ventricles. And so I thank you, Jeffrey, for these numbers, the normal values. So I was just kind of following along Jeffrey's sort of prompt of this. What measurements do you use for your subarachnoid spaces at the vertex with concern for benign macrocrania or benign enlargement of the subarachnoid spaces? Two names for the same thing. Or do you measure?
Yeah, this was pretty new for us. So, you know, we probably introduced these measurements probably 6 months or so ago now. And it was kind of a debate, you know, which numbers do we use? You know, there's 3 different measurements here. You know, if you do 3 measurements and one of them's off and the other 2 are normal, what do you do with that? So we don't do that interhemispheric width. I just decided to do the craniocortical width and the sinocortical distance. Just, you know, before we did these measurements, it was kind of just all, you know, people were kind of just saying, yeah, they look a little bit big, but it's not that objective. So I don't think the data on this is that great per se, but I think it's better than nothing. So we do those 2 measurements just to give us a little bit more objective data. And then the other kind of tag along question, I was curious, you know, as far as the ventricles themselves, you know, I think there's, you know, reasonable data for the preterm infants to track ventricular indices. We use ventricular index for following the lateral ventricular size. And you know, those go up to the post-menstrual age of, you know, 40-ish weeks. But if you have a term infant, you know, like this, that's, you know, 3, 4, 5, 6 months old, there's not really, as far as I know, a whole lot of data for normal ventricular size in a, normal term infant. How, in that particular case like this, like how do you guys describe whether the ventricles are normal or dilated? I struggle with that.
Subjective.
Yeah.
My bias is I hate measuring. I feel like we measure things at ultrasound that we never do on CT or MRI. So like, why are we measuring all these things? But that's what I do.
Yeah, the number of discussions that I have had with colleagues and sonographers within my group about which one of these 3 measurements is the best is more than I can count on my fingers and my toes. And everybody seemed to have a favorite. And it was really challenging to try to figure out which one we were going to, because there were solid camps of, no, I want it to be sinocortical, and no, I want it to be cranial-cortical, to the point where we were having full on like arguments. And so where I came down on it, and where I basically said, measure how you want to measure. And then if we're doing follow-ups, make sure you're measuring the same way you measured the first time, right? So you at least have some internal consistency. I am of the craniocortical distance. I'm a straight up and down measurer person myself. But I can understand that there's challenges with all of them. But for us, and as well as with the ventricular measurements, I think what's most important is to either make a decision and do it that way. So you at least have some internal, continuity. Or if somebody has chosen to do it a particular way, make sure that every follow-up ultrasound is the measurement as close to what was done originally.
And I think one other part, even in this image here, the 2 measurements are going to be different on each side. Like if you measure the width on the right side, it's going to be bigger than what you have measured here. So, and I don't think that's really accounted for in the original papers that gave this data. So I think that's another, we just decided to measure the bigger of the 2 sides, but I don't know what the right answer is to that either.
Yeah, this is another one of those, wow, it'd be really nice to look back at how, and this all again now with more modern machines and modern, really beautiful, because again, so many of these, if you look back at the types of ultrasound machines and the types of ultrasound images that we were getting when we were actually making a lot of these rules, our imaging has dramatically changed, and what we can see and the structures that we can see is significantly better. It'd be interesting to go back and really relook at all of this with the new technology that we have.
Yeah, that's definitely
true. And I have a feeling Judy's.
Yeah, and we've been having that discussion with our NICU about the ventricular index measurements for the preterm infants, because the Levine index, what they call it, that data is from like 1981, and then there's newer, more updated data sets that have more recent that go down to younger ages, just because like we talked about, there's more preterm infants that are surviving. But if you compare those 2 data sets, the more recent data has generally larger, for the different percentiles, larger measurements for the ventricles. And I think that's probably due to higher resolution. And like you're saying, for this particular topic, the extraaxial spaces, if you look back at those actual papers where they did these measurements, the image quality is nothing like we have now. So it's definitely a point where I think we just don't have great data for it.
Great yet. I also think it's funny when you look at the, okay, 2 points. Number one, I think, yes, describe the enlarged subarachnoid spaces, but also make sure it's the subarachnoid spaces. We've had several cases of missed subdurals. And also there's an increased risk of subdural hemorrhage or subdural hygroma, like an anechoic subdural collection in patients with enlarged subarachnoid spaces. I think it's funny, and like looking at all the older literature, how important it is to like show the blood flow going all the way across. But these days you can see, hold on, I'm going to skip to 2. You can typically see the displaced arachnoid mater to be able to distinguish subarachnoid space from subdural space. So like you can see the little bridging arachnoid granulations and vessels, and then that displaced arachnoid mater. So just make sure you're actually looking for that little line, because oftentimes they will be anechoic. And then going back to some other example. So this companion case where these extraaxial spaces are like, oh my gosh, big. And sometimes I think we forget to look at the history. So if it's a super premature kid, maybe a neurodevelopmental delay, don't call it benign macrocrania if it's a patient who maybe has atrophy instead. You have to have history for that. So, most commonly benign macrocrania is like 6 to 9 months. And, usually the ventricle size is normal, but sometimes it can be large. But like we've had several cases where we have a former 22-week kid who now has these big ventricles or big extraaxial spaces, and it's probably not just benign macrocrania. I don't know if you guys have any light to shed on that.
Yeah, that was one other thing when we were deciding to implement these extraaxial space measurements. Kind of the same thing we were talking about. We ended up deciding to do it in all kids just because if you only pick a select few patients, it just gets inconsistent with their sonographers remembering to do it. But we do it on these preterm infants now that we're doing for other purposes. And there actually is a paper that talks about if I think it's on sinocortical width, if it's over, I think 3.5 millimeters, then that has a poor kind of long-term developmental. And I like you're saying, I think it's a kind of a describing underlying atrophy. So we do. I don't think that our neurologist or anybody actually uses that number for counseling or anything, but that was at least one other facet of us when we were introducing those extraaxial space measurements that I think it still does potentially have some implications for preterm infants as well as these kind of benign macrocrania patients.
Yeah, and I just have a quick little protocol tip. We have found that adding a cine clip, as I'm with Judy and the love of cines, adding a cine clip with very zoomed in images of the extraaxial spaces is also really helpful to make sure you're not missing a subdural in there.
Yeah, agree. I have another mantra. Number 1, the choroid plexus should be the brightest structure in the brain. Number 2, never trust a kid with congenital heart disease. I find that more often than not, they have some sort of subdural collection. Now, is it clinically significant or not? We could debate that, but it's probably important that they know, especially if we're following them. Yes, we did get a CT in that patient. Oh, I knew I put the measurements in here somewhere. So we measure the frontal horn width and the ventricular index because that's what our neurosurgeons have asked us to do. I know there's some debate about measuring versus not. And more my question is, if it's a patient who's had, who's developing a porencephalic cyst, where do you put the lateral margin of your cursor? Like, do you include that porencephalic cyst? Do you try to sort of guesstimate where the ependymal ventricular lining is?
This is where measuring is so hard.
I hate measuring.
Why? And there are moments, and I will be the first to actually admit that in these cases, I will say significant interval enlargement. Because sometimes I think the measurements can actually be really confusing, because you can make it measure whatever you want to.
Yeah.
And this is where, especially if the NICU calls down or the neurosurgeon calls and says, yeah, but what are the measurements? And I'll say, why don't you come down and we'll look at it together and we can talk about it.
Oh, snap.
Well, because you're absolutely correct. And this is where I think, it's come up a couple of times in the discussion. And I think it's a really important point. There are many, many different ways to measure, and there are many, many different things that we can look at, and being able to provide them with the exact information that they want and that they need is as important as providing any information at all. And so that's where I'll actually say, why don't you come down here and show me what you want me to measure? I'll measure it for you. And then we can measure that moving forward. And that's where that conversation can be really helpful. It can be hard to do in the middle of a really busy clinical service, and neurosurgeons are notoriously challenging to get a hold of. But when I do, especially in these challenging cases, I find that it's always helpful.
And one other quick comment, just to bring up a couple of questions that were brought up in the chat, back to the conversation about subdurals, particularly in the setting of, concern for NAT, or even if it's just an incidental finding, they come in with macrocrania and you happen to see this. There's one comment, like we were talking about with having, better quality and higher resolution imaging, if you see these little thin 1 to 2 millimeter subdurals, does that trigger a full NAT workup? there was a nice paper that was just published. I think it just came out in this month's Pediatric Radiology that their suggestion was that any subdural should trigger an NAT workup. We've kind of had those discussions locally, and we've kind of talked about it. Kid has these very, thin, relatively benign looking subdurals. Do you guys still pursue an NAT workup, or how do you guys handle those?
For outpatients, yes. We bring them in. We have our child advocacy team come evaluate the patient because safety. I'd rather overcall than miss a non-external trauma. Inpatient congenital heart disease, premature follow-ups, no.
Okay, so for like a NICU baby, if you happen to see a little subdural, just comment on it and follow up, but no specific, most of those kids have been inpatient their whole life, so not particularly high NAT risk, but okay.
You say that, but then my child advocacy team about a month ago told me about some case of a NICU, non-external trauma. Anyway, so it's hard. We probably have time maybe for one more case, one more topic. And this kind of goes along our theme of higher resolution equipment these days. There's a ton of normal variants, and we see more and more normal variants all the time. So this was just a routine screening, had ultrasound in a premature kid, and there were these thin little echogenic things along the cavum septum pellucidum. I've seen these called sequelae of prior infection, like syncytiae, which is not the case. These are just normal variant septal veins. And I feel like I see these all the time, especially in premature kids. How about this one where we have these branching, actually this is the same patient. We have these branching echogenic foci in the deep gray nuclei. You can probably see it better on the sagittal, these little echogenic chicken feet almost, with the mineralizing vasculopathy or lenticulostriate vasculopathy. So I've had two different conversations. One where I'll have colleagues put this as impression number one, rule out torch infection. And then some people bury it in the findings and say, non-specific mineralizing vasculopathy or whatever. Do you guys have life advice for this one?
I
or no. Oh, sorry.
Go ahead. I'd actually really love to hear what you're saying.
I know. Well, our neuroradiologists tend to say that is normal. And unless it's like too much, but they've never really said how much is too much. So once again, I would love to hear your guys' thoughts on that. Like, what is too much?
I've never actually seen them on a follow-up MRI. Like if a baby has an MRI for some other reason for follow-up, I've never seen the correlate.
I don't read brain MRI, so I don't know about that per se in my practice, but I do feel like, especially with our newer machines, especially with the linear high frequency probes, and the higher the frequency, the more you see. I feel like I see this constantly. And we have a very large congenital heart disease population here, and they're getting constant head ultrasounds. And so I'm just seeing it constantly. And so I routinely do not comment on them.
Even in your findings, Erica?
No.
All right.
It's not. If there is a specific question about torch for another reason, then I may put it in there. If there's, especially if there are other findings that would push towards it. But if it's a routine head ultrasound,
Yeah, I agree. And I'm honestly not a big fan of either of these terms. I think that I've read that this kind of mineralizing that, that either on CT, oftentimes we don't see these as calcifications, and even pathologically, I don't think they've really been shown to be mineralizing. And then kind of the vasculopathy term, I think, implies some degree of pathology. So I kind of think it's a little bit of a misnomer, but yeah, I'm in agreement with both of you. I definitely tend to downplay this. If I see it, I don't tend to bring any specific attention to it. I do put it in the findings, but I don't call out any specific attention to it.
All right, last, how about the same question, choroid plexus cysts?
And then a quick chat question is,
Oh, yeah.
any of us seen a torch infection that only had that lenticulostriate vasculopathy finding and nothing else? I'm probably going to say the same thing about these cord plexus cysts. I think that I have not either. I've not seen an example where either with these cord plexus cysts or with that lenticulostriate vasculopathy that it kind of pointed them in the direction of something they didn't already know. So that's kind of also kind of lead to why I don't draw a lot of attention to it.
I actually did look this one up because I got tired of, like every single head ultrasound has at least one tiny cord plexus cyst.
Yeah.
They're not true cysts. They're also different from like the cysts that you see in adults. And then, you know, when they say large or multiple, they're associated with certain syndromes, but they don't say how many is multiple. And then I do think that 1 centimeter is typically the size cutoff. And I have found a couple of different papers where it's like, unless there's something else going on, ignore the choroid plexus cyst. I just really quickly want to show you my last case because we've made this mistake several times where we had an infant who had a large scalp collection and we questioned either an epidural hemorrhage or a subdural hemorrhage. And so you can see this like ellipsoid collection along the extraaxial space. And always it's a patient who has either like a subgaleal hemorrhage or a caput or like crazy soft tissue edema. And this is an artifact, right? So there's lots of assumptions that an ultrasound machine makes. This is mirror image artifact. It's the same artifact that you get when you have a liver lesion and it shows up in the lung because it's reflected off the hemidiaphragm. It's well described. If just keep this in mind, it's probably artifact. Move your transducer over just a little bit. Yes, we got a CT in this kid, also not an MRI for multiple different reasons. But you see these, oh my God, huge subgaleal hemorrhages. Move your transducer over, get rid of that artifact. Don't recommend a CT just for this. Thank you.
Yeah, we had an almost identical case about a month ago that ended up being a calcified cephalohematoma, but the ultrasound appearance was very odd. It was kind of similar to this. It's definitely confusing. So yeah, the scalp stuff can definitely distort and give you all these weird artifacts.
Yeah.